Good morning, Michael. How are you? You can listen to me. Sorry, I just want to say to you that we will have interpretation for this meeting. So Bernardo Herrera will be the interpreter, and he's joining in a moment. They are.
Hello.
Hello.
Good morning.
Hello. Sorry, we had a huge problem here with the Wi-Fi. Our apologies, but it seems it's finally running well.
No problem.
Thank you, sir.
And Michael, you could listen to me.
Yes, I can hear you.
Perfect. Thank you. Now, I'm just saying that we will have interpretation. They are working in the configurations, in settings, but once we set the interpretation, you must see a globe icon in the three dots, and then you have to select the English channel and stay there during the meeting. That's all.
Perfect. I have it turned on, actually.
Okay. Okay. Perfect. Thank you, Mike.
Un segundo, ya le cuadro.
Hello, Mike. Can you hear me?
Yes, I can.
Hi, Mike. Please talk again.
How are you, Ricardo?
Voy a decirle a Mike que hable. A ver si es que... Mike, can you hear me?
Yes, sir. Yes, I can
Oh,
hear
so
you.
the instructions to set up the interpretation are on chat. There should be a little globe icon on the bottom of the Zoom screen.
Yep, I have it turned on.
Oh, okay, great. So you can hear me.
Yes.
Can you hear me still? No. No. It's set on English. Or no?
I'm hearing you in English.
Right. I mean, if you click on the globe icon,
Yes, I
then
have
get
I have the voice translation turned on.
okay. And on speaking into English.
Yes.
Okay, let's try this one more time.
¿No se escucha? Es que no se le tiene que escuchar a Mike. Se le tiene que
Michael,
escuchar al
sorry,
otro.
can you
No se
hear
le
me?
tiene que escuchar a...
Yes, I
Could
can.
you
al otro. Sí, entonces
could
estamos bien.
you turn on the interpretation? You select the English
Okay,
channel
Mike,
because
I think
Bernardo
we
is already
can
in the English
start.
channel and I think that you cannot listen to him.
Sean bienvenidos a la última etapa de estas jornadas académicas. Esperamos que hayan disfrutado de su almuerzo. Les solicitamos gentilmente tomar sus respectivos asientos para dar continuidad a la agenda planificada para esta última etapa. Vamos a cerrar con broche de oro este último bloque, contando con 3 destacados expositores de la esfera de emergencias de los Estados Unidos. A partir de este momento nos complace abrir un bloque académico de altísimo nivel y de carácter internacional. Nos enlazaremos en vivo y en directo con destacados especialistas de los Estados Unidos, quienes compartirán con nosotros herramientas de vanguardia en docencia, cuidado crítico y operaciones aeromédicas a través de nuestra plataforma virtual en tiempo real. Les invitamos a mantener la máxima atención a las pantallas del auditorio. Para dar inicio a este magno segmento, es un verdadero honor presentar al doctor Mike Caduz, representante de la prestigiosa NAEM de los Estados Unidos, quien nos impartirá la conferencia Educación en Prehospitalaria. Bienvenido, doctor Caduz.
Thank you. Thrilled to be here. Thank you for the opportunity to join you today and to share some thoughts on EMS and education as you look to the future that is the EMS pathway that you're all continuing on as you leave the educational realm and head into the so-called real world. As they shared, my name is Michael Cadus, and besides for being a board of directors for the National Association of EMTs, I also lead the Falk Health Institute, which is a global company. We do EMS all over South America as well as Europe and North America. I lead our initial education efforts, so I see EMT and paramedic students every single day as we work to ensure that they're prepared to take on the challenges that we're going to see in the field of EMS over the next 50 years. It's a really fun but also challenging as we recognize that the majority of things that we see in healthcare are going to change within the next 10 years. Someone has probably told you that over the next 10 years, about 50% of the things that we do in medicine will change. Some of those are paradigm shifts. We used to not put tourniquets on anyone. We used to say it was a last-ditch effort. We used to say that it was going to ruin the limb and that we were going to have hypoxic and ischemic injuries. And now we say, if you can't control bleeding, put on a tourniquet, and if that doesn't work, put on two. We've really seen some paradigm shifts in EMS over the last 20 to 30 years. And we've seen the same in education. My goal is to connect those things for you today and really demonstrate that the evolution of EMS and the evolution of healthcare and medicine and how we train for those fields is supposed to change. That's part of the process in healthcare. I think a lot of things that we go to school for, if you think back to algebra or language arts, the definition of a noun doesn't change. The definition of a preposition hasn't changed in our lives. So we really get in the mindset of education of thinking that what we learned in school should be the end all be all. It will be what we learn and what we remember for the perpetuity of our careers. But in healthcare, again, we know that's not going to be the case. And sometimes it can be a challenge in our minds to bridge those two gaps and to really understand that what we learned in school is likely going to change. And again, we sort of have to be okay with it. So if you're okay, I want you to join me on this journey as we talk a little bit more about the changes we've seen in healthcare and what that means for the changes in healthcare education and simulation. Many of us can remember back to what we've seen on television or what we've maybe even seen out in the field in terms of patient care. Every patient that had a traumatic injury got put on a long backboard. Maybe that was a stubbed toe or a laceration to the leg or someone who fell out of bed a couple feet onto a very soft carpeted surface. Just 10 years ago, that patient would have gotten a cervical collar and would have been placed on a backboard for transport to the hospital. They then would have proceeded to lay on that hard, firm surface for another 4 hours while the emergency department CT'd or x-rayed their neck, their cervical spine, their head, their back to ensure that nothing was wrong. We've moved on in healthcare to say that actually we probably shouldn't be putting people on backboards altogether. We'll talk a little bit more about that here in just a minute. We also used to put patients on in mass trousers. These were inflatable pants. Think of a blood pressure cuff, but fit over all of the legs. And the thinking was that if we inflated those mass trousers, we'd push the blood from the legs back up into the extremities and back up into the heart and lungs where they could get oxygen. Weird, the research on that showed that it really doesn't work. We return about 250 cc's of blood back to the heart, and that's about it. We found that maybe they're good for some splinting, but we really haven't found that there's any benefit to a shock patient for those types of things. We used to give oxygen to every patient that rode in the back of the ambulance. In fact, in the United States, we would say that's their ticket to ride. If you're in the back of the ambulance, you're going to be on some nasal cannula or an on-rebreather mess. We've since found, and the American Heart Association has said since 2010, that that's not good for our heart attack victims or our stroke victims. Those patients that are short of breath, absolutely, give them oxygen. But the patients that are breathing normally with no increases in rate or depth, the American Heart Association says don't. It causes vasoconstriction, which is really not good for a patient having a heart attack or a stroke. But again, for about 40 years, that was your ticket to ride in the back of the ambulance. We also used to say large volume IV fluids for every single patient. If your blood pressure wasn't 120/80, we pumped 2 large bore IVs in each arm, and we pumped saline, liter of saline after liter of saline in, hoping to try and increase the blood pressure, only to come to find out that saline, as we always know, doesn't carry oxygen and isn't going to improve the patient's outcome. And now we're sort of okay with a little bit of permissive hypotension in our patients, especially our trauma victims. We need to replace blood with blood. We used to also say lidocaine was our choice for antidithrhythmics, and every patient was a load and go patient. Come to find out, there's really no research that says a 10-minute scene time benefits a patient any more than a 12-minute scene time or even a 20-minute scene time. While surgery is the ultimate goal for most of our trauma victims, that getting them out and managing their pain and their life threats actually has been proven to be very beneficial to patients. In fact, we should be staying on scene until we stabilize those airway, breathing, and circulation emergencies, because we found that we're sort of better at it when we're in the field rather than in a moving ambulance. So again, this golden 10-minute principle, or this platinum 10 minutes that we hear about in the textbook and that we learn about, really hasn't been demonstrated to value the patient when we look at clinical outcomes. So what has changed? Well, just as healthcare and medicine ever evolve, so too does our clinical thinking, our clinical judgment, our data analytics, and this outcome-centric evaluation of our patients. It's no longer, did I get them to the hospital? But it's, did they have a positive outcome? Did we treat their pain? Did we manage this patient so that the hospital could continue their care and that they could go home? If I give my CHF patient, my congestive heart failure patient, 2 liters of fluid en route, I may get them to the hospital successfully, but But if I've put a bunch of fluid into their lungs and made their pulmonary edema worse, then we're in the same situation we were, and the hospital is going to spend the next 4 days trying to pull that fluid off. So we've changed our way of thinking on spinal immobilization. We've moved to a spinal motion restriction. We're saying some patients probably need a C-collar and to lay supine, but our ambulance gurney does that. Other devices do that besides a long backboard. And then as soon as we can get them off of that long backboard and have them lay supine, we should be doing that. The outcomes clearly demonstrate that there's value in having our patients off of those backboards, unless it's a very short time period. In fact, we're saying that car accident victims, motor vehicle collision victims, for the most part, can probably get out of the car and be stabilized from there, that we actually manipulate their cervical spine more, getting them out of the car, than we do just having them stand up and walk in a comfortable position and then having them pivot onto our gurney. We've moved away from things like pelvic binders that we used to think were instrumental. In our cardiac arrest days, we used to think airway first and lots of medications. Since, again, 2010, the AHA has said CAV, we're doing compressions, fast and hard, and that's our goal. And then maybe get that AED in there. Why? Because chest compressions and the AED, the early defibrillation, are really the only two independent predictors of survival in cardiac arrest. So we've moved away from ventilations and oxygenation and moved back to compressions, which ironically is what we were doing when CPR first started to come around in the early 1900s. We've moved into other fields where we're doing a dual sequential defibrillation. We're finding that actually changing the vector of the electricity as it travels through the heart may actually increase survival of patients. So if our anterior lateral placement of our AED pads or our defibrillator pads don't work, then maybe we just need to change those, and that may actually improve. And in fact, we're seeing a lot of agencies do that here in the United States. We're incorporating mechanical CPR into our systems. We're saying that this machine can do really high quality compressions as long as it's positioned right and it's monitored for the duration of the cardiac arrest. And then I don't have my providers having to stand up in the back of an ambulance, having to be unseat belted in the back of the ambulance, and I can just actually stay on scene and continue the resuscitation. We've also adapted our post-arrest care. We're considering things like therapeutic hypothermia in our patients, things not even 10 years ago that we would have ever imagined doing in the pre-hospital setting, and now it's really becoming standard practice. Dual sequential defibrillation has been adapted by numerous agencies in just the last 2 years. We also used to run with this concept of rapid transport to get the patient in the back of the ambulance and get them to the hospital as fast as possible. However, we've changed that. In fact, we're bringing care to the patient more and more than we ever have in the past. We recognize things like large vessel occlusions in the pre-hospital setting. We bring CT scanners to ambulances through the use of mobile stroke units that are bringing CT scanners and neurologists who can remotely look at it, and then thrombolytics that can be given in the pre-hospital setting, substantially reducing those times where it takes the patient's signs and symptoms to the administration of medication down to less than 20 minutes. And we know that has a huge impact on mortality and morbidity of our patient. We're doing other things like bringing ECMO, the heart-lung bypass machines, to the patients. Europe is cannulating these patients in the pre-hospital setting, setting up the ECMO and driving the patient to the hospital on heart-lung bypass. These types of advancements in technology are coming to an ambulance near you, and we know that the technology has already been demonstrated to improve patients. We need more data to analyze that on a large scale, but again, we're seeing these technology become more available in the pre-hospital setting. We've added technology to the back of the ambulance. Now, instead of giving oxygen to every patient, we have other options for patients that are shortness of breath. Maybe that's CPAP or continuous positive airway pressure, something that was just for ICUs just 10 years ago, is now standard practice for most EMTs and paramedics across the country and across the world. We've introduced capnography. One of the fastest adoptions to healthcare is capnography, which was for the most part primarily just used in operating rooms for anesthesia. The first agencies and healthcare departments to get capnography outside of those operating rooms was actually the pre-hospital setting, was EMS. We were showing capnography in the pre-hospital setting not just for confirmation of ET tube placement, endotracheal tube placement, but we were utilizing it for things like seeing if your bronchodilators are working when administer things like albuterol and Atrovent. We were seeing if our congestive heart failure patients are improving. We've even seen that patients, we can monitor their fluid resuscitation for shock using capnography as a metric. Now we see capnography in all of our hospitals and all of our systems. Why? Because EMS was an early adopter and said this is something we can use. Now, you might be asking yourself, well, okay, we've seen some clinical advancements. We know that, healthcare is changing and ever evolving. I don't know that everyone is on board with that. I think if I talk to a lot of my students, again, they're in a mindset that, what I'm taught now will be what it is forever in perpetuity. And again, that goes back to our, primary and secondary education where Pythagorean's theorem hasn't changed, algebra hasn't changed. But in healthcare, again, we're telling you a bunch of this stuff's going to change. And it's not necessarily that we were ever wrong. It's really more just focused on the fact that we probably just didn't know. And so education must also evolve for this. Many of you probably remember back to your primary and secondary school, sitting in lectures, having to memorize things, sort of being threatened by your instructors that this is going to be on the test, and if you don't memorize it, you're never going to have a successful career, you're never going to get into college or post-secondary education. Certainly that was my experience as well. You had to demonstrate your knowledge through the test. And then at the end of the day, you were sort of said, okay, you're competent and you can go off into the world because you passed this test. Now, education, just as it is true in healthcare, has to evolve and has to change as well. We've moved on to things like simulation in the classroom. We've moved on to case discussions, actually going through real, true outcomes in our patients. We take them from the doorstep to the hospital, and for the most part, we can actually look at what happened to them after they left the hospital. We've encouraged reflection. Our students here at the Health Institute have to do journaling. We know that there's a huge retainment of knowledge when students reflect later in the day on the things that they learned earlier in the day. So having our students go home and write a short reflection on the day, or leaving their field or their clinical shift and sort of reminding themselves what they learned, we know that not only does that improve their clinical performance, but it also improves their affective domain. They can look back and empathize with their patients. They can sympathize with the patients. Something that we would have never considered teaching you in your EMT or your paramedic training was this affective concept, this having feelings and making sure that we can empathize or sympathize with our patients. And now we spend true time making sure that our providers actually have a heart for this and have a heart for caring for our patients. We know that this will likely improve the rates of burnout, but it also ensures that people who care about others are the ones that are joining the healthcare field. We've also rarely done team training in healthcare, but now if you take a BLS, a basic life support class, or an advanced medical life support class, or a pre-hospital trauma life support class, we operate in teams. It's no longer this solo performance that you're out in the field by yourself with no resources and sort of stuck to, mend for yourself or fend for yourself and try and survive out there. Now we say you have resources. You can look things up on your phone. We can get on WhatsApp. We can make a phone call. We can look up our protocols. We can use the internet, and we can use our team for our resources. And we want our students to feel that they have a backup system. Why? Because everyone else in healthcare does it. No one in a hospital, no one in a clinic is sitting there by themselves thinking, okay, I have to care for this patient all alone. They've got other providers, they've got other clinical specialties that they can call on to help them in the field. And we like that. We want our students in the pre-hospital setting to have that exact same ramification when they're in the pre-hospital setting. Instead of panicking because they're stuck managing this patient alone, they know that they have a team. We also look at outcome-based quality improvement. When we take care of patients, we care about what happens to them in the hospital. If I thought my patient was having a stroke or a myocardial infarction, I want to know if the hospital thought the same thing. If I deliver my patient to the hospital and I thought, oh, they're having a stroke, and it ends up they were having a toe pain and a toe laceration, then I missed the mark completely. But that not only changes our clinical practice, it also changes our quality improvement process and our continuing education. Instead of going out into the field and me doing the exact same continuing education as my partner and as everyone else in my service, and here in the United States, the same continuing education applies to every single EMT and paramedic in the country, we should be looking at if your patient outcomes. If I took 5 or 6 patients that were having a stroke to the hospital and they successfully survived and I met the metrics that my agency told me I needed to meet, then I probably don't need to do a lot of continuing education on that topic. I clearly met the mark. But there are probably some areas where I can look at my patient outcomes, what happened to them in the hospital, and say, oh, we did miss the mark there. There's some continuing education opportunities there. Now, you might be thinking, okay, well, that seems all and good, but how does that impact me in the pre-hospital setting, and how does that impact me on my education? Well, simulation, simulation, simulation. That is the magic word in healthcare education. It's not just healthcare providers in the pre-hospital setting, but it's our hospital providers, it's our doctors, it's our nurses, it's our physician's assistants, it's our nurse practitioners, it's our respiratory therapists. Everyone in healthcare is using simulation. Why? Because we want you to be practiced when you go out into the field, and that means that I can't just put put an airway mannequin in the middle of the floor and say, okay, go ahead and intubate that patient. I have to raise your stress levels by adding some outside environment. Maybe we're intubating outside in the sun. Maybe we're intubating with people around us. Maybe we're intubating the patient in the dark. All of these things increase that fight or flight response that we all learn so much about. Well, if I induce a fight or flight response a few times and I give you the confidence that you can actually do this skill with people around in a hot environment for a difficult airway, then I know that I'm inoculating you to your stress. Just like we inoculate against a disease, we give you a really small dose of something and then your body builds up immunity to it. I can do the same thing to stress. I can put you in stressful situations, cause that stress response. Maybe it's taking care of a sick patient who's a pediatric. Maybe it's taking care of doing a procedure that I haven't done in a long time. If we practice those things with a little bit of stress, then we inoculate you against that future stress. It just sort of becomes second nature. If you ask experienced providers why they never get worked up, that's why. They've been in those stressful situations, they're confident in how they do it, and they can work through that process. That's stress inoculation, and that's why we like simulation to do it. We're going to stimulate your senses, we're going to overwhelm you to a certain extent, not to the point of failure, but we're going to overwhelm your senses where they're going to increase that fight or flight response. And we're going to prove to you that you can actually do these things even in a stressful situation. You might think back to the days of old where we had, you would assess the mannequin's pulse and then someone would have to announce the pulse rate, or an instructor would have to say yes or no, or the airway is patent, or the airway is open, or the breathing is good. We've moved on in our simulation practice to start involving family members, and our students love it because they get to bring their families in and we get to do simulations with their kids or their grandparents. We're going to increase that fidelity. Instead of doing an assessment on a classmate, they're doing an assessment on one of their colleagues, mothers or sisters or brothers or kids. And now all of a sudden they have to show a bit more respect and they can't joke around as much, which is actually exactly what I would like them to do in the field, is to be professional and to be polite and to be empathetic and compassionate. So we're building those bridges by doing that in simulation. We can do it. I can do other things. I can have a patient become hypotensive. I can have a patient become tachycardic and wait and see how long it takes for my EMT or my paramedic student to notice that change. What does that do? Well, it teaches them that in the field, they need to monitor those things. Instead of having an instructor standing over their shoulder and saying, you need to repeat a blood pressure, it's falling, I can just have my mannequin do it in that simulation environment. And then instead of having a stable patient and an unstable patient, they've now learned that reassessment every 5 or 10 minutes is incredibly important in the field. And I didn't have to lecture a thing. We also talk about team dynamics in simulation. What happens when two partners disagree? If you haven't had that experience yet, I promise at some point in time early in your EMS career, you're going to have an opportunity where you're going to have patients that are going to disagree with each other. And you're going to have to work through that, just like it happens in the hospital. We have nurses that disagree. We have physicians that disagree with the treatment. It involves a consensus process. We know that we don't understand everything about healthcare yet, and that's going to force us to have those conversations and to have those discussions. But if we rely on our laurels in education and say that, well, we've always taught them to fend for themselves, we've taught them that they always have to be the leader of whatever they're doing, and we don't ever give them the opportunity to have those discussions, to contrast those things, then we want them. We do this with our students all the time. We have a protocol, it's a sort of like a survivor protocol game where they're given a patient and they have to find a protocol that works. We know that most of our patients don't read the textbook before they call 911. They don't read the protocol book before they call 911, which means sometimes we have to evolve our protocols. Sometimes we have to use more than one protocol to take care of a patient. I want my students to feel comfortable knowing that that's an option for them and having, again, been in a stressful situation where they have to do that before. And then we look for diagnosis. I mean, sometimes you'll hear people say diagnosis is a bad word in EMS, and I couldn't disagree more. If your patient has an amputated finger, guess what the diagnosis is? It's an amputated finger. If your patient's having a heart attack and you can tell that on your 12-lead EKG, that's exactly what the hospital is going to diagnose the patient with as well. We want our providers, through their education process, to be coming up with a diagnosis. As an educator, I care more about how they got there than what the true diagnosis is, but there is a ton of value on having the ability to figure out what's wrong with your patient. We will always have patients get to the hospital without a diagnosis. The diffuse abdominal pain, for example. Maybe it's a cholecystitis, maybe it's an appendicitis. I don't know, but I do know that the patient's having abdominal pain and I can treat that. But if the patient's having a stroke or a heart attack, I do want them to be able to make that diagnosis because it's going to impact their treatment. I want them to recognize a stroke or recognize a heart attack and get the patient to a facility that can care for that. Why? Because the data clearly shows that if we get the patient to the right place, then they have a better chance of survival and survival without disability. Those things are important to me, and they only come about if I put you into those environments when you're in simulation. I can lecture about American Heart Association guidelines, I can drive those, but I can't do it easily without simulation. The true learning, where I can get you to take something from your short-term memory to your long-term memory, occurs when we put you into those environments. So why does this matter as you sort of look back on your EMS education and look forward to the field? Well, because that's likely what your continuing education is going to look like. We've really moved on beyond sit at a computer and click through modules, or stand in front of someone or sit in front of someone for an hour and then take a test at the end. We've moved to an environment where we're expecting to put you into an environment where we're going to, again, stress your senses and force you to make decisions, collaborate with those around you, and come up with the best course of action for your treatment. What does this look like as we go into the future, as you embark upon your EMS careers and sort of ask yourself, okay, the next 5, 10, 15, 20 years in EMS, what's that look like? Well, I think this is going to be the best part of being in EMS. We're very young. Healthcare has been around for centuries, but EMS has been around for about half a century, which means that we're finally coming into our prime. We're really starting to figure out what we should be doing in the pre-hospital setting because it works, and what we should be doing in a patient's home, what we should be doing as an ancillary service, and we're starting to see paramedics used across the healthcare spectrum. We're not isolated to the pre-hospital setting anymore. We see ICUs hire, we see intensive care units hiring paramedics, bringing them from the pre-hospital setting into the pre-hospital setting. We can bridge the scope of practice there. And that's the fun part. This is the best time to be in EMS. We are bringing technology forward. Maybe it's ultrasound, maybe it's blood transfusion. These are the things that are coming to your ambulance and your pre-hospital setting around the world. What does that mean for education? Well, it means things like virtual reality and augmented reality. Maybe it's wearing Oculus glasses and having your team all standing around a patient and being able to treat the patient. That technology actually already exists. It's not widespread in education, but the technology is getting cheaper and better at the same time, which means we're going to see in the environment. Imagine your next advanced cardiac life support class or your next pre-hospital trauma life support class where you're standing around with your Oculus glasses on, looking at the patient, starting the IV, doing the BVM ventilation, splinting the extremity, controlling the bleeding, all in a virtual reality environment. Imagine augmented reality where you can see a patient and you can interact with that patient, but they just sort of exist as a figment of the imagination of the artificial reality system. We can do things like eye tracking of you in the field. We're making EMS safer every single day. Our units here in Southern California already do this. They recognize fatigue in providers by tracking their pupil movement while they're driving. This is incredibly important because it keeps them safe. We have new restraint systems in our ambulance that are keeping you seat belted, and if God forbid there is a collision, we're keeping you in one place, which is exactly what we need to do to keep you safe. Other things that are coming to EMS, wearable analytics. This is a great area of research that we're doing here right now. We know that EMS has stressful moments, but we don't know exactly when those stressful moments are. Well, why does that matter? Well, if we know when those stressful moments are, then again, we can inoculate to that. So wearing heart rate monitors and blood pressure monitors and perspiration monitors, we can start to tell when the most stressful moments are in EMS, and we can start to respond to those accordingly, and we can start to take a proactive approach to do that. With that, healthcare is ever evolving, healthcare is ever changing. The things that you learned in school are going to change and evolve over the future. And that's the way it's meant to be. That's the way it's supposed to be. This is a change from what we've learned in our primary and secondary education. Just as healthcare has changed, so too is the education process that got you there and the education that's going to keep you clinically relevant and clinically competent. Thus, we have to be continuing to ask ourselves, what's next, what's forward coming, and what's the best for my patient? Thank you for the opportunity to join you today and share some thoughts on the future of EMS and education.
¿Alguna pregunta para el ponente? Nos dirigimos con una pregunta. Saludos, no sé si me está escuchando.
Yes, I can hear you.
¿Sí?
I can hear you.
Doctor, qué gusto saludarles de Ecuador. Hacemos aquí educación y también hacemos educación continua. Y ha mencionado algo que es súper interesante, subir los niveles de estrés o los desafíos a los cuales se le puede someter al estudiante durante la formación. eh, ¿Cuál es el rango? ¿Dónde se pierde la línea entre lo que puede ser beneficioso de estrés y lo que ya empieza a perjudicar al estudiante dentro del estrés? Y lo sobrecarga. ¿Existe una sobrecarga cognitiva o lo despista y hace que el estudiante se vaya completamente del escenario y se centre únicamente en los aspectos que le están estresando? Lo digo porque en Ecuador existe esta, quizá una creencia de que más estrés es mejor, o el escenario donde más sufra el estudiante es mejor. Entonces me gustaría que usted nos ayude con eso. ¿Cómo dejar claro esta parte?
I think that's a great question. We struggle with that in the United States as well. I think this is where it's important to make sure that the educators have training and to recognize that. Early on in someone's educational career, we focus on easy things that we can do to increase stress to an environment. Maybe that's a bystander who's a trained person that we've brought in and told them what to do. That person may be a family member to the patient. It may increase the stress level of the patient. But I would add that person in individually for that scenario. I'm not going to throw multiple things at them early on in their career. Another really easy one that we do is we add smells to the room. I think we've all walked into that patient that has had a bowel movement or that has had some sort of skin infection that has an odor to it. Those things very easily stress out our students, but they do not typically push them to a point of no return. Again, a patient that has a foul odor in their room where they're doing the simulation, a hot environment or a cold environment, it gives them a stress, but it doesn't move them to where they feel like it's an unsafe environment. Now, part of that comes before the class is taught, right? While I'm teaching their lecture, while I'm leading up to the simulation, we're building that safe space. That means that I've put them in previous scenarios and they felt like it's not impossible, that there is a possibility that they will succeed and be successful. So that's what we do with our students. And then we build. Then I might add a bystander and put them outside. Maybe then I might put them in the back of an ambulance. If I add these things slowly over time, then I avoid putting them into those no-win scenarios or putting them into a point where they shut down because they're cognitively overloaded.
Muchas gracias, Eric, muchas gracias, Mike, por su presentación. No tenemos más preguntas. En nombre de la Universidad UT y de los paramédicos de Ecuador, agradecemos por su tiempo y por su magistral ponencia. Gracias y esperamos poder contar con usted en una futura ocasión.
Agradecemos al doctor Caduz por sus valiosas directrices sobre los estándares globales en la formación de los profesionales de la salud. Continuamos en nuestro bloque internacional y mediante conexión virtual en tiempo real recibimos al doctor Eric Bauer en representación de Flight Bridge ED con una ponencia de alta complejidad clínica, manejo del estatus de epiléptico refractario y superrefractario. Bienvenido.
Hello, everybody. My name is Eric Bauer. I'm the CEO and founder of Flightbridge Ed. Thank you for having me for this conference. I want to talk today about refractory status epilepticus, and I want to add some new evidence to a big problem in the status seizure patients. Ketamine is one of those new drugs that I want to discuss as a second-line pre-hospital rescue agent in these patients after benzodiazepines. I really want to highlight the current evidence based on emergency department data, ICU data, and pre-hospital data throughout the United States and the rest of the world. So what are we going to cover today? We're going to define the problem, status epilepticus, refractory status seizure, and why benzodiazepines often fail in these patients. I want to analyze the pathophysiology, why seizure activity is such a bad thing for our brain, why seizures become progressively harder to stop the longer they continue. I want to look at the pre-hospital perspective. I want to look at why EMS systems rarely carry a true second-line agent, which has been found to be much better at slowing these seizures down. I want to look at the current evidence for ketamine as it relates to ICU, emergency department, and now pre-hospital data throughout the world. And then I want to look at the practical implications. What's the best dosing? Is this a safe route to go? And what does this mean from a protocol design standpoint in your current area? I want to talk about a little bit of a background. What is status epilepticus? If we define this, this is a seizure that's lasting longer than 5 minutes. Or if you had a patient that had 2 or more seizures without a return to baseline meaning consciousness between them. So if you have a patient that never returned to baseline, never returned to a conscious state where they were able to answer questions, know person, place, time, and event, that would be considered status seizure or status epilepticus. What we don't want is we don't want refractory status seizure activity. And that is seizures that persist or return despite adequate cumulative dosing of the standard of care, which has been for a long time benzodiazepines. Two critical time points that I want to point out. Number one, at the 5-minute mark, that's the point at which normal seizure termination mechanisms within our body have failed. And so when we start having prolonged seizure activity, this is where those prolonged seizure mechanisms have begun. Time point 2, from a critical standpoint, is at the 30-minute mark. This is at the point at which a long-term consequence is really an emphasis. This is where we start having brain death. We start having neural death.
She got
an injury that
put herself to
alters
bed.
our. Say that again.
It seems like there's quite a few people that are not muted, Eric, so I think it keeps cutting you off.
Okay. Just let me know when you want me to start back. So I just want to repeat the 2 time critical points, just make sure we didn't miss this. At the 5-minute mark, this is the point at which normal seizure activity should be terminating. And we have mechanisms in our brain and our body that have failed. And so this is at the point where seizure prolonging mechanisms have begun. At the number 2 time mark, that's at the 30-minute mark. This is the point in which long-term consequences can be seen. We can start having neural death, brain death in different areas of our brain. And this is where, that injury is altering the network, all the mesh, all the neural mesh within our brain. And we start having ultimate brain death. So this is obviously a chronic problem, right? When we go on adults and children that have routine seizure activity, this is not something that we're going to often see. I'm not saying it doesn't happen. We're usually not going to see prolonged status seizure in a new onset situation. I'm going to highlight a few examples of where that could happen. But this is a common high stakes situation. And I think this is what's called a a high acuity, low occurrence situation as well. I think reflecting on my career of 35 years, I've only had a few status seizure patients, and I've had other patients that have had what's called pseudo seizures. But really, I can't count on one hand the amount of times I've had a true status epilepticus patient. So 15 to 30% of pediatric status seizure patients, specifically looking at the pediatric population, cases are refractory to conventional first-line therapy. And so what that means is the standard cocktail of whether that's Ativan, whether that's Valium, whether that's Versed, those benzodiazepines that we commonly use as a first-line agent are often not going to work. And so when we start looking at this at a more optic, big, and we bring it kind of closer together, status seizure incidence in children is estimated to be 10 to 42 cases per 100,000. So again, it's a small incidence. It's a small occurrence type of a call. 30-day mortality rises more than 30% after 1 hour of ongoing seizure activity. So that's a significant amount of time. We talked earlier, 5 minutes and 30 minutes. Those are those two time periods that we have to be cognizant of. And so when we start seeing status seizure activity lasting for more than an hour, mortality skyrockets to 30%. So why do seizures become harder and harder to break as the time evolution continues? When we start seeing that convulsive seizure persist, we start having this inhibition of these excitation imbalances. They progressively get worse, and the receptors that the benzodiazepines, which are called GABA-A receptors, they move into the cell and they become less available. So when we look at this from really a step-by-step manner, right? We have persistent depolarization that happens. This continual neural firing drives extracellular glutamate concentrations upward. So we see that glutamate skyrocket. Number two, the GABA-A receptors that we know the benzodiazepines act on, they move inside the cell. If they're not outside the cell, we have a inability to activate those receptors. So we want those outside the cell. And so as time goes on, we start seeing less and less of an ability for those benzodiazepines to act on the GABA-A receptors. Then we have MDNA receptor upregulation. This is an excitatory receptor that increases the cell surface, and it actually reinforces the seizure and makes the seizure last longer and continuous. And then we have what's called a self-sustaining seizure. This is step number 4. This is where we start having inflammatory processes that independently basically potentiate or make the seizure activity worse, and that overall worsening worsens outcome over time. So how do we look at this from the standard of care? Everything we do in medicine, whether we're talking about emergency medicine in the ED, ICU medicine, or pre-hospital medicine, we're always evaluated by the standard of care. And so treatment escalation in the hospital, for example, first line, again, standard of care pretty much across the board where we're talking about ER, ICU, or pre-hospital is going to be a benzodiazepine, whether that's going to be your Ativan, your Versed, or your Valium. And remember, it's all about activating the GABA-A receptors or those channels. And as the seizure lengthens and gets longer and longer, we have less of an ability to hit those receptors because those GABA-A channels close. All those GABA-A receptors move into the cell. Second line, a lot of times, are going to be things like phenytonin. You're going to see valproic acid, things like that. And those are medications that we're not going to readily use in the pre-hospital setting. We're going to definitely use Keppra a lot of times, but Keppra is really not going to be a drug that is used as a first-line treatment in a true onset seizure activity. It's going to be used prophylactically, maybe in a traumatic brain injury patient, somebody that you see increased intracranial pressure, or you're worried about potential seizure activity. Keppra is a great medication to give prophylactically. But we're talking about emergent situations where we have a status seizure, again, 5-minute, 30-minute time phase. And then we get into a more prolonged seizure situation where we're now looking at a second line or a third line drug. And we can often use propofol. That's going to be something that's going to be used in the hospital. For the long time, we had at places I worked, we had phenobarbital as a second line agent. But now we have better medications, and that is ketamine. So I want to talk about ketamine more in depth as we move forward. And ketamine has become a drug that is used on, in most cases, I know in the United States, on really every ambulance. And so I want to talk about the importance of this medication. So where's the gap? When we start seeing gaps in the different pre-hospital settings, agencies, 2 of 33 state EMS protocols designed any type of second line agent in seizure activity. And I think that's the importance. When we're talking about the US model, I'm not sure how the Ecuadorian model works, but the US model, we have every state has a way of delivering EMS care. It can have a state guideline, or it can have county run or delegated practice guidelines. Texas is an example of delegated practice. So each county can, based on their medical direction, deliver a specific guideline. Oregon is the same way. Kentucky, where I'm at, they have a state guideline that can be altered based on state approval, but there's definitely hoops you have to jump through. So what this slide is really saying is that we don't have a good understanding across the whole United States where I work, when you're looking at it as a whole, as a second line drug. There's not many second line drugs that are available. One of the issues that you have for these seizure activity patients is IV access. IV access is frequently difficult, obviously, for a patient that is in an active convulsive state. And so when we start looking at options for second line medications, we have nasal route, or we have an IM route. And ketamine is a great option for those patients. So why ketamine fits the pre-hospital model? Well, ketamine is a drug that really does amazingly at not potentiating other medications. And so that gets into some physiology, talking about plasma protein binding. And ketamine is bound differently. It only has a 40% plasma protein binding rate. It does not bind to standard proteins like other medications like fentanyl or morphine or Versed. And so the potentiation of ketamine is very, very small. So it is very common to not see respiratory depression. Now, that doesn't mean you're not going to see some respiratory depression in these seizure patients, specifically status seizure patients, because you already have given them benzodiazepines, which we know will cause respiratory depression, and those are highly plasma protein bound. One of the amazing things about ketamine is it's hemodynamically stable. It has sympathetic properties. It blocks parasympathetic receptors called muscarinic and nicotinic receptors, and it stimulates, as a rebound, a sympathetic response. So your hemodynamic stability in these patients are going to be maintained, which allows for better compensation over the time period, much better than a benzodiazepine like Valium or Versed. As I said, you can give this intranasal or IM. It's already on the trucks in most cases, and it has a pretty rapid onset, usually 90 seconds. If you're giving it IV, maybe a little longer if it's IM. I would recommend, if you're going to give this IM to a status seizure patient, to give it to a large muscle group. I would do intra-thigh on the anterior thigh, just like we would do epinephrine 1 to 1,000 in an anaphylactic situation. So when we start talking about ketamine dosing based on current research, right, we're all driven off of research. I've got 3 different papers I want to highlight. Some of these papers have, I should say, small sample sizes, but this is a fairly new area of study. So the first one is Schlepke et al. This is out of Palm Beach County EMS. This is where Dr. Peter Antevy from the Antevy system works as their medical director. They give a standard 100 milligram flat dose. It can be IV, IO, IM, or intranasal. In pediatrics, they go 1 milligram per kilo, and this is given after sufficient Versed dosing has failed. So they're using ketamine still as a second line agent. They're still giving the benzodiazepine and trying that method before going to your ketamine dosing. Perlmutter et al. In 2023, Harris County EMS, which is in Houston, Texas. There was no pediatric dosing. This is only adults, and you can see they gave 2 milligrams per kilo or 4 milligrams per kilo IM. And so if you have done recitative sequence intubation, the standard dosing for ketamine is 1 to 2 milligrams per kilo. And we know the standard excited delirium dose for ketamine is 4 milligrams per kilo. So they're mimicking those doses. And again, this is second line. This is given after sufficient Versed had been given. And then Williams et al. 2024. This is a literature review. Again, observational in nature. So it's the lowest level evidence, 1 to 2 milligrams per kilo. Again, standard RSI dose. And then up to 3 milligrams per kilo IM when IV access was unavailable. And again, it's very difficult in many cases if you have somebody that's seizing to start a line. Doesn't mean you can't do it, but you need to be cognizant of needle sticks and safety of you and your crew. So you can see that there's been other studies. I just listed off 2 of these 4. And you can see that seizure cessation was in the first study was 63%. In the second study, the second line here, you can see that 46% termination. This is a high hospital study. 28% reduced minor delirium, hypertension, and 4%. Perlmutter, as we said, was only 6 patients. So these are all pretty small sample sizes. And then in Schlepke, that's the biggest one to date, largest pre-hospital data set to date, had a 98% seizure cessation in adults, 73% of pediatrics. Those are massive, massive numbers. So this is just highlighting Perlmutter's study and why it matters. Again, small sample size. This is Harris County ESD. All of these places down in Houston from a fire department and EMS standpoint are all ESDs. And this is a pretty large area, 65,000 annual 911 calls, so very busy system. Only 6 pediatric patients were evaluated between September 2021 and March 2022. Again, they used 2 milligrams per kilo IV or 4 milligrams per kilo IM, and they had a lot of luck in treating these patients. Remember, when we start talking about pediatric status or refractory status epilepticus is time critical. When we get past that 30-minute mark, again, in a pediatric patient, let alone an adult patient, we're starting having neural death. So it's really important for us to be aggressive, to be on top of it, and to have this second-line medication available in these cases. As we know, one of the problems with status seizure patients is the airway. We give 10, 15, 20 milligrams of Valium Versed, you are going to knock out their airway, and now you're dealing with a second issue. Now you have to intubate them. Now you have to put them on a mechanical ventilator. You're managing their airway from that standpoint, and you lose the ability to really assess their seizure status, right? So it is important to be quick in determining if a dose of ketamine is warranted. In Perlmutter, all 6 patients achieved basically complete stop of the seizure based on ketamine use. No patients were intubated. So again, I said that's one of the problems. There were a few patients that you can see 3 of the 6 had to be ventilated with a BVM, but they attributed that to the previous dosing of benzodiazepines, and only 1 of the 6 had a recurrent seizure on arrival at the ED. So pretty positive results. Again, 6 patients, very, very small sample size. needs to be studied in more depth. SLEP-Key, as I said, this was a 7-year study, pretty large study group in Palm Beach County. And this is a pretty large area from a standard EMS system, about 1 million patients. As you can remember from my previous slide, 100 milligrams dose of ketamine that was not milligrams per kilo. On the pediatrics, it was standard for adults, and then 1 milligram per kilo for the pediatric patients. Results in the SLEP-Key, again, 57 patients on a protocol cases, 98% of those patients converted. 1 to 2 minutes, paramedics consistently reported seizure termination within 1 to 2 minutes after ketamine administration, and 9 of 9 of these patients achieved 100% seizure termination with ketamine and Versed as a first-line medication. So a little bit more in depth on this, 11 of the 15 children in this situation had complete termination of the seizure activity. 2 of these patients were actually judged retrospectively as non-seizure activity. So, and then 2 received intranasal ketamine, suggesting a possible limitation of that route. So out of the 4 patients that didn't convert, 2 retrospectively, again, judged to be non-seizure activity, and 2, basically they're saying that the intranasal route probably was not the best route. We need to be using IV or IM. So is this safe? Is ketamine safe? Ultimately, we need to stop this seizure. Across 81 pre-hospital cases in the SLEP-Key et al., no clinically significant complications were tied to ketamine whatsoever, including any unplanned intubations. Again, that really does make these calls much more complicated. I know in the patients that I've had, intubation has been part of those in 2 of those cases. BVM use, sometimes we have to go back to BLS procedures. We need to manage the airway. Benzodiazepines will definitely knock out somebody's respiratory drive. And so that is not a ketamine issue. That is a benzo issue. Vital signs, pre-ketamine, SpO2, end-tidal CO2s, throughout the ongoing seizure activity, improved after ketamine administration. And it gives us a very wide therapeutic index. Doses up to 1 milligram per kilo over protocol amounts were still associated with stable airways and hemodynamic stability in those cases. So I think the important emphasis of this slide is just to say that we had no unplanned intubations. It stopped the seizures. We had improvement in vital signs. We did not have to give ventilatory support with an ET tube or intubation. Had to manage the airway with BLS maneuvers, but that was for a short period of time, and you have a very wide dose range with ketamine administration. I know there's a lot on this slide. I think the big thing about this slide is time matters, and the thing I want you to emphasize is the area in red. One of the most interesting observations in these studies in the recent literature is really the necessity to give the medication quicker. The quicker we can give them medication, the quicker the seizure stops, the better outcomes that we're going to have. Remember, as I said, we start getting those longer time periods, you had a huge 30% increase in mortality rate. So earlier ketamine administration is the key. So from an application standpoint, what are the implications for designing your guidelines or protocols? I think we have to give paramedics the authority to escalate to ketamine after a defined benzo dosing. I don't think it needs to be a time period. I think after a benzo dosing, we need to give the paramedics the ability to make a clinical decision rather than repeating benzos multiple times to rapidly transition to ketamine. I think standardized dosing is something to consider. Flat or weight-based dosing, IV or IO dosing might be warranted, but sometimes just a standard flat dose might be easier. So I think the consideration needs to be what is going to be best for your system. I think we have to monitor our patients just like all patients. Vital signs are vital. And so continuous pulse oximetry, waveform capnography, cardiac monitoring in these patients is a must. And we need to be consistent, do vital signs every 5 minutes, and do our best at maintaining an understanding of their status. I think we need to educate on the potential positives and negatives of intranasal ketamine. Is it something that works? Can it work? I know it's simple. You know, we have less of a possible issue with maybe needle sticks or worrying about getting IV access in these patients. And so, you know, I think IV, IM routes are going to be optimal, but intranasal is definitely one of those areas, even though 2 of the patients in the Perlmutter case did not, or actually it was a Slepke case, did not respond well, and they attributed it to the intranasal dosing. It definitely is something that needs to be studied further. And I think we have to always track our outcomes. I think you don't know what you're doing, how you're doing it, how well you're doing it, unless you're looking at quality metrics. And so we need to audit every chart. We need to look at these things. And I know that there's amazing agencies out there that do a really good job at this. And if there's anything I can do for your system to help you build a quality management system, please reach out to me after this talk. So what are some limitations and open questions that we can ask? We need more published data rather than looking at 1 or 2 EMS systems. We need to study this in more depth. Remember, from a hierarchy of evidence, we need randomized controlled trials. That sometimes is difficult. This is a low occurrence, high acuity situation, meaning we don't see many of these, 10 to 40 in every 100,000 pediatric patients. So it's a very small amount. When we start looking at in-hospital flow data, including seizure reoccurrence, any EEG findings, any final diagnosis, when we start looking at that stuff, a lot of stuff like that is hard to find and it's not available. So I think one of the things that we use in an agency I work for is we use ESO. It's a great charting program, and we get outcome data on all of the transports that we provide care for. And so I think that really helps. We know that ketamine reliably stops seizure activity. It may not always be the best option at controlling, electrographic seizure activity, but as a second-line agent to stop status seizure patients, it definitely is warranted and it's reasonable. Again, no randomized controlled trials have been done to compare pre-hospital ketamine directly against benzos, so that needs to happen. There is a current prospective multi-center randomized controlled trial for pediatric refractory seizure activity that is underway and should give us a much better ability to extrapolate this and make better decisions as a whole from an EMS standpoint. We know ketamine is an emerging medication. It's feasible in many, many options. We're using it for pain control. We're using it for sedation. We're using it for our induction agent for resuscitative sequence intubation. And we know that it's being used in patients with severe depression. But I also think it is a warranted medication. It's reasonable to use as a second-line option, as I've portrayed. Remember, pre-hospital data now, including the largest data set, that was a Slepke study et al., published to date, shows high rates of seizure termination with favorable safety profiles. Again, we're looking at incidence of intubation, incidence of hemodynamic collapse. We know that those things did not happen. Remember, when we start looking at the GABA-A receptors, we start looking at the 5-minute and the 30-minute marks, the time phase, we start having prolonged seizure activity. Those GABA-A receptor move into the cell. We have less available for the benzodiazepine to activate on, and that's where ketamine really comes into play. It acts on a different receptor. Those are going to be NMDA upregulation receptors. It's not about a best second line agent. It's about doing the right thing for the patient, right? Benzos are going to be the standard of care still. ketamine should be number 2 on our list. And as I said, right, we have that one large prospective randomized control trial that is ongoing, and I can't wait to be able to see the potential data set from that. And I'd love to answer any questions if there are any questions.
Muchas gracias, Eric, por la presentación. Magnífica. Todos nuestros participantes la encuentran bastante enriquecedora. Al momento no existen preguntas. Sin embargo, desde la Universidad UT, en nombre de los paramédicos del Ecuador, queremos agradecerte por tu magnífica ponencia. Es un tema bastante relevante, algo que, como tal lo indicaste, no es muy estudiado. Hay mucha evidencia escasa que tenemos que revisar a futuro. En este contexto, agradecemos por tu ponencia y nos dejas grandes ideas para llevar y el uso de la ketamina como una nueva alternativa para el manejo del estatus epiléptico refractario y superrefractario. Muchas gracias nuevamente, Eric, y esperamos poder contar contigo en próximas ocasiones.
I'm guessing that means I can start, right, Ricardo?
What's up, dude? How are you?
You good, man? Good. Nice job. Awesome. Well, good to be back with everybody. We are going to talk about the anatomy of a scene flight today. So we just updated some of our courses inside FoamFrat, and Ricardo reached out to me and said, I think it would be valuable to go over the part in the flight ops class about the anatomy of a scene flight. What happens when you call a helicopter? You know, what should you expect? What can you prepare? How can you operate safely around the helicopter? And so that's what we're going to get into. I do have the chat open. I don't have the meta glasses on to translate all of that. So maybe Ricardo can text me and tell me what, if you guys have any questions as we go through it. But I want to break this down, and I don't know what the model looks like in Ecuador. I don't know how that looks. I did a little bit of research. I know you guys do have helicopter systems in that area. But what was interesting when I went from working on an ambulance to then working on a helicopter is what goes in before you even get to the patient. And it was really interesting because on the ambulance, when the pager goes off, you just go, right? You put the address in, you find out where the patient is, and then you drive to that patient, right? Then that's it. Your partner gets in the ambulance, you turn the lights and sirens on, you call en route, you just go there. And so if you think about a helicopter responding, there's a lot that goes in between a flight request coming in and then like the moment you actually lift off. And so I've enjoyed the experience of working both ground and air. So I've been at Lifelink 3 now for almost 10 years, but I just recently started working on the local ambulance service here as well. So Lifelink 3 is up in the Minnesota, Wisconsin area. And the stuff that I learned transitioning to the helicopter really reframed my thinking, because I used to always think, why do the helicopters always deny the request? And what does the weather have to be perfect before they can lift? And I didn't realize all the stuff in between a flight request and when you're actually clear to lift. And so that's what I want to go over. And then we'll get into some of the nuances of that as well. So when you call and you say, hey, I need a helicopter to come out here, we got a patient that needs to get, to this hospital, whatever. They page us out, but they don't tell us what they're paging us for. So all we know is that we have either a transfer or a scene. Sometimes there'll be a search and assist, but usually it's either a transfer, which is going from one hospital to the next hospital, or it's going to a scene where you're actually landing at the landing zone that the fire department has set up for you. And so the reason they don't tell you you're going out for a 5-year-old that was in a bicycle accident, or you're not going out for, a 93-year-old lady who, fell down a flight of steps, they don't give you the demographics because they don't want that to influence your decision as to whether or not you're going to take that flight. And not that you would hear it and be like, oh, that doesn't sound serious. More so on the other side of that, where you hear it's a kid and you're like, man, we got bad weather moving in, but I think we can make it. I mean, my God, this is a 5-year-old. We got to get in there. So they don't tell you any of the demographics, anything about the mechanism of injury, nature of illness, until you say the flight is a go. So this flight request comes in. OCC checks the weather. I don't know if you guys use the same term, but OCC is our Operation Control Center. Some people say Operation Command Center. And essentially, it's not dispatch. It's separate from dispatch. It's separate from the people who are telling you, hey, you got a flight request at this area. And their job is to look at the weather and make sure that the risks are minimal. They want to make sure that the pilot is on board with the weather checks and that there's no weather moving in. And so you have two different systems working at the same time to see if they come to the same conclusion. And so our OCC is part of LifeLink as well. And they work in the same area, but they have two separate jobs. These guys are really good at looking at the weather patterns. Some of them are even like actual meteorologists. They've gone to school for this. And then you have the pilot that's looking at the weather. They're looking at the ceilings. They want to see that, is this going to be a situation where we start having clouds come down around us and we can't see? And so there's two different operations. There's a visual flight program, visual flight rules, which means when you're flying, you have to always be able to see the ground. You can't go above the clouds. You have to always be able to look down and say, I see the ground. Sorry, my daughter is beeping my dog because he's in here and she thinks he's lost. Give me 2 seconds. I saw her walk in here and then she started beeping him with the little thing. So that's visual flight rules. Now, instrument flight rules means that you can fly above the clouds and you can fly with just your instruments. Well, the program that I work for is visual flight rules. So we have to always be able to see the ground. So as the ceilings start coming down, that's going to impact our decision, right? Because not only do we have to get to the patient, but we have to get them safely to the hospital and then get safely back to base. So the pilot checks the weather and the duty time. Duty time is how long they are able to fly in a shift. And actually, I shouldn't even say fly. It's just how long they can be on shift. And so they could not fly all day. And then all of a sudden they get a flight request right at the end of the shift. And they go, oh, I have to turn it down because that would put me in the red for my duty time. And the FAA regulates all of that. So interesting aspects that I did not even know about on the ambulance. Now, once they decide to accept the flight as far as the weather looks good, then the pilot's going to consult with the med crew and OCC. And so the idea with this is that we all come together and we make sure that there's nothing that anybody's seeing that makes them feel unsafe about this flight. And so there's a saying, 4 to go, 1 to say no. And so you have the pilot, the paramedic, the nurse, typically. I mean, there's a bunch of different demographics. And then you have OCC. And if they look at it and they go, listen, we're not going to be able to safely complete this mission, then they turn down the flight. And you don't necessarily get back in bed. Maybe if it's nighttime, you do, but you don't take that flight. Sometimes it's an easy decision, right? You look and the METAR says you're in IFR conditions. You can't take the flight. And they just say, yep, we're turning it down for weather. But let's say that we do accept the flight. We decide, yeah, weather looks good. Everybody's good. We all have a risk assessment that we complete at the beginning of our shift. And then the pilot is going to submit a separate risk assessment for that flight. And so he submits this, and the questions that this asks are, is there a chance if let's just say it's a daytime shift, is there a chance you may have to put your night vision goggles on? Like right now, it stays light out till 9:30 at night. But as soon as it starts getting colder, it starts getting darker earlier. And so we can still take flights at night. Like that's not a big deal. But we just need to figure that into the risk. The other thing that they'll look at is How experienced is the crew? So, you could have a really experienced pilot and a really experienced nurse, and then you have a paramedic who just started flying, right? There may be a couple months off of orientation. So all of that goes into the risk assessment. The OCC has to approve that risk assessment. They say, yes, that looks good. Every once in a while, because all of this stuff happens quick. Maybe the pilot forgets to check the box that says that the highest obstacle that they may encounter is X amount. So the OCC will say, hey, I noticed you didn't check the night vision goggle box, or you didn't check the highest obstacle box. Is it okay if I check that? And they're like, yeah, that's fine. So they check that, and then you are clear to lift. So now we are able to go. Now, this whole process, 10 minutes, 10 minutes, it doesn't take that long. It's a lot of stuff happening within a short period of time. Usually they'll pre-fill out parts of the risk assessment, so they only have to put in the parts that are esoteric to that particular flight request. And so they put it in, and we all walk out to the helicopter. All right, so we're pulling it out. Usually the helicopters here, because it gets so cold, we don't keep them outside. In the summer, we do. They can sit outside. But they're in a hangar, and you can see we have this cart here, and he's backing this out. We got wing walkers that we'll have on both sides. And the idea when we get out there is we're going to complete a 360 around the entire helicopter. So we're going to walk around the entire thing. And honestly, I think this is a good idea, even on an ambulance, to make sure there's no compartments open, to make sure nothing's leaking. So you, the nurse, and the pilot all walk around the entire helicopter. If it's at night, you have your flashlight, and you're not walking around sitting there looking on your phone and just going through the motions. You're actually looking for things. Well, what are you looking for? Here's the things that we're looking for. The 360-degree inspection ensures that no detail is missed before liftoff. And so what we're looking for is any variables that could compromise the flight. And so here's what those are. So you may have heard the term FOD, F-O-D, foreign object debris. This is stuff that's laying around. This is candy wrappers, gum wrappers, a flashlight that fell out of your pocket, a saline flush that fell out. Any of these things, that's what we're looking for. We're making sure nothing's laying around that could get sucked up into the rotor system and compromise the flight. We're also looking for loose straps, caps, or covers, secured doors and hatches. There's so many little cowlings and little openings on the helicopter, so that way the mechanics can get in and check a chip light or check all of these areas. And we want to make sure those are all closed down. And then pitot tube covers. So the pitot tube is what measures the airspeed when you're flying, and it's this little thin cover or a little thin cone. And you can get bugs that get in it and start to make a nest, and then that can compromise the accuracy. So we put these little covers over them when we leave them outside. You got to make sure you take those covers off. Fluid leaks, ice damage, and then confirmation that all equipment and the blood cooler are properly latched. And then the goal is to eliminate any variable that could become a hazard once the rotors are spinning. Now, this is really important. So we all carry a little pouch with us that has ketamine, fentanyl, midazolam. It's got our controlled substances in it. And so it's tagged, the medic has one and the nurse has one. And so when we come on shift, we switch those out. We sign our little NARC form. We want to make sure we have those, right? Because that's the medications that we're going to need if we have to perform a RSI, if we have to intubate, if we have to control pain, seizure management. And those are the things that we want to make sure we have. We want to make sure if you have blood that you have it with you, because we have to take it out of a cooler, out of the fridge that it's in, put it in a cooler, and then put that inside the helicopter. Make sure you have your phone, your radios, all of that. Because it's not like an ambulance where you can pull out and be like, oh, I forgot this. And, let me jump out real quick. Once you lift, every leg of that flight is planned. And so you can't lift. And then if you're flying and you're like, oh, man, we got to turn around and grab the blood, that's a huge inconvenience. The pilot has to start their checks all over again. It's not what you want to do. All right. Now, once we get up in the air, we have to establish ground contact And so when we establish ground contact, what we're looking for is we're trying to identify the landing zone, where they're going to land us, and what it looks like. And part of our guidelines, part of the FAA, is that we have to have a ground contact, someone we can communicate for our mission profile. And so this is typically called like a landing zone coordinator. And usually it's a fire department. And we go out and we train with the different fire departments and we tell them, hey, this is how big. We need it 100 by 100. We want it free of power lines and trees and obstacles. We don't want people wearing baseball caps right by where we're going to land. These are all the things that we would include in that. And then they are prepared and, they have little landing zone kits that they can put out. And so we establish this ground contact, and then we're going to contact them on the radio. So usually whoever's requesting us will say, can we switch to like Mark 4 is one of our channels. There's STAC 5, Mark 1, Mark 2, STAC, whatever, Fireground Red. Every radio has like these point-to-point channels, so that way you're not talking on like the main channel, right? And so typically we have to be pretty close before we can actually reach them on these point-to-point contacts. But the way we call out on the radio is very uniform, and it's supposed to be this way. And you guys may have heard this before, but the phrase that we say in our head is, "Hey, you, it's me." So if I say Hudson Fire from Lifelink 3. Right? So Hudson Fire, this is Lifelink 5 on Mark 2. How do you copy? The reason we say the hey you, the Hudson Fire, is because we want their ears to perk up, right? We want them to know, oh, they're talking to us. Hudson Fire, and then we tell them who we are. This is Lifelink 5 on Mark 2. How do you copy? And so let's say they come back and they go, Lifelink 5, this is Hudson Fire. We got you loud and clear. We can hear you. And then you'd say, Hudson 5, this is Lifelink 5. We're showing about a 5-minute estimated time en route. So we give them an estimated time en route, an ETE, instead of an ETA. An ETA would be the time that we will arrive. We're giving them an estimated time en route. And then we ask for a description of the landing zone. Now, the paramedic or nurse is sitting right here. The pilot's usually, is sitting on this side. And then you have the paramedic or nurse sitting in the back. And we're all listening to this. And we're trying to imagine what this landing zone is going to look like. Is it on a highway? Is the traffic controlled? We're all talking about this and game planning on the way there. And so when you're giving a landing zone report, these are the main things that we want to know. We want to know major landmarks. And this is because sometimes when you're flying, you can't see the accident. It's covered by a tree line. It's, behind a building. There's certain things that obstruct your view. But if you can say, hey, it's by the baseball field, or it's by the soccer field, or it's by the hospital, or it's by this highway, then that gives us an idea because we can slowly start to zoom in as to where you are. The other thing I'll say is if you hear us, let us know because we'll stay on that channel so that way they can talk to us. And so if they say, yeah, we're going to be landing you by the baseball field or by the high school, those are very easy things to identify when you fly into a community. The other thing we want to know is landing zone surfaces. And so is this a field with really high grass? Is this on a highway? Is this in dirt? Are we going to land and the skids are going to start sinking into the dirt? So the LZ surface is important. And then identifying any hazards, trees, telephone lines, big billboards, drones are a big thing now. And not just like recreational people flying drones, but also like when they're doing a search for somebody and they'll put the drones up if they're doing a search and rescue, they'll use the drones. And so we want to make sure those are all, nowhere near where we would be. So that way those are not a hazard. All right. Now, when you're setting up your landing zone, we ask for 100-foot by 100-foot perimeter. And so there's a couple things to keep in mind here. the helicopter will always land into the wind, right? So if the wind is blowing at me, if the wind is blowing at the helicopter, that's the way I want to land. And the reason is because that wind blowing gives me extra lift. And so as I'm coming down, it allows me to control me. I'm not flying it. It allows the pilot to control it better. If the wind is behind you, it can push you down into the ground. So we always land into the wind. So that way we have a nice controlled landing. So you don't need to tell us the direction of the wind. Typically, the pilot has a way of telling that inside the actual helicopter. You can, if you want, but the pilot is looking at his gauges to figure out where the wind is coming out of. And the wind can shift, but they always want to land into the wind blowing at their face, not the wind blowing at the back of their head. Now, as we come down, landing into the wind, the LZ coordinator needs to be somewhere between like this side and this side, not in front, but somewhere on the side where they can see the pilot. We want to be able to see the LZ coordinator from the front seat of the helicopter. And then we will ask for an additional person to be the tail rotor guard. Now, this does not mean you get right next to the tail rotor and, you're holding right here to block it. You need to be a good distance away, like a very good distance away. But the idea is that if for some reason you saw a person running over here because, oh my God, that my daughter's in that helicopter or something, the tail rotor guard could signal to the LZ coordinator that could signal to the pilot that somebody was running up. And so this is important because they'll all be on radio, so hopefully that doesn't happen. But this allows these three to communicate because I'm going to get out of the helicopter. My nurse is going to get out of the helicopter. And so then you're going to have these three just watching this area. Now, this doesn't happen a lot. The worst I've seen is, a car or a cop maybe driving too close to the LZ. I don't typically see people running at the helicopter. But that's what this is for, is to keep an eye on all of this stuff. Now, we are wearing white phosphorus night vision goggles. There's two different types. There's green phosphorus and white phosphorus. And so you see how bright these lights are. And so that's why we do ask to not have any heavy scene lights. Sometimes cars will put their brights on and they'll all put their lights on so that way we can see the LZ. We can see it just fine. So just those little LZ lights are fine on the corners of it, but try to not blind us, because what happens is you get such a huge glowing blur that you can't actually see where you're going to set the helicopter. So you can have your lights on, just make sure nothing's shining bright into the LZ. Now, this doesn't happen a whole lot in Wisconsin or Minnesota, maybe more of a thing in Ecuador. But if you land and you have like an uphill and a downhill, you always want to leave an approach from the downhill side for obvious reasons, right? Because if I get out and I walk uphill, I'm essentially making myself taller, which is how you get the worst haircut of your life. So you don't want to do that. You want to make yourself shorter, right? So that way the rotor blades don't actually hit you. So you exit out the downhill side so that way you can safely leave. So don't leave uphill. It seems like common sense, but there's been lots of accidents where this is what occurs, especially in mountainous terrain where you are landing on the side of a mountain. So always exit and enter on the downhill side. Now, we always tell people, especially I'll go back to this picture right here. When we get out of the helicopter, I'll just use my little marker here. We get out on this side just because this is where our door is for the crew, and then we would load the patient on this side. So when we get out, we will walk right about here, I would say. I'll just draw like a little X here. And we will look at the pilot and we'll hold a thumbs up like this. And the pilot has to give us a thumbs up, and then we can exit the rotor disc. So the rotor disc is this, right? And so this is the most dangerous spot to be in. You always want to make sure you're talking to the pilot, because The worst time to be in this spot is either when you're entering, or when they're starting the blades, or when they're stopping the blades. When they first start up and it's going kind of slow, the rotor blades kind of dip down a little bit in certain areas. And so that's when it's the most dangerous. So I want to make sure before I walk in that I got a thumbs up from the pilot, because what if he decided I'm going to shut down, right? And then I start walking in while he's shutting down, those rotor blades are going to dip down a little bit. And so, theoretically, it could hit your head. So we always tell orientees, family members, anyone during our brief, do not enter or exit the rotor disc until you get a thumbs up from the pilot, and that's for us. And then nobody should enter or exit without a member of the flight crew with them. Now, I can get out and I'll walk over here while the discs are turning and, open the door and start to get stuff ready. That's fine. I couldn't go out here and walk around and come in. And you never do anything back here. That's a no-go zone back there. All right. Let me get rid of my marker here. All right. So the other thing that's important to keep in mind is visibility. When we're going out to a scene, we put on our ANSI, DOT, whatever approved yellow reflector vest. And in the winter, our jackets have reflection on them as well. This is important anytime you are responding to a scene, especially in a helicopter, because, they're usually landing helicopters by main highways. Even if it's not on a main highway, if it's at a baseball field, a lot of times you land at the baseball field and they say, hey, hop inside the ambulance. We're going to drive the flight crew to the crash up the road because we couldn't find anywhere to land you there. So we always want to make sure we have those vests on. There's a ton of first responders that are killed every single year because they get hit by a driver, right? And, while wearing a reflector vest does not mean you're not going to get hit. It is just another layer in that protection. Now, something that's interesting when you're responding to a car accident is all the vehicles seem to have these random areas that they park, right? So we got like the fire truck, and we have the cops, and we have the ambulance. And I want to explain this. You guys probably already know this. When I built this class, I explained this because flight nurses don't have this type of training. They don't know about emergency temporary traffic control, or the reasoning behind why people park in certain ways on an accident. So I thought it was worth going over, and then I'll get into some of the extrication stuff as well. So let's say that the first person that gets there is usually a police officer, right? Because they're sitting here looking to write speeding tickets, and, they get to this accident first. So you can see the accident over here. So the cops will get there and they will start putting out something they call a taper. And so they may put a flare, some sort of warning sign way over here, another warning sign, and then some cones to begin this taper, right? Now, when the fire trucks get there, they are going to park in something called the fend off position. And the idea here is to block the lane where the accident is, plus one more lane. Now, even though this is in the grass, we still wouldn't want vehicles coming through here. So we would block off this lane and this lane here. So the fire truck will, way up here will block this off. Now, not all of the trucks are going to be way far over here. Some of them are needed to run hydraulic lines for extrication. So they may park closer, but you do want, the idea is to put as much metal between the oncoming traffic and the people, right? So if somebody were to not be paying attention, they're texting on their phone, and they run through all this, they don't see the warning signs, we would rather them hit the side of this fire truck than to keep going on and hit the scene where these emergency responders are working. Now, if you're the first ambulance on scene, you are going to probably park up here and do the same thing. And that's because you're going to get out and start rendering care. Sometimes the ambulance services are full-time, like where I work now. We always have staffed ambulances in the town I'm in, the fire department is on call. So typically we will beat the fire department to the scene. And so if that happens, we want to block the scene with the ambulance. And so instead of parking over here, we would put the ambulance right here so we can block this off. And we're pointing the vehicle, the emergency vehicle, in the direction we want the traffic to go, right? So let's just say the school bus is coming down and it starts seeing this. It's telling them move to this lane, right? And so maybe, if the ambulance was like this, then the fire truck would come in and go before the ambulance because those are bigger. Some areas, they actually have emergency vehicles that are just made for blocking. And so they pull in and they block off that entire side, these big, thick metal trucks. Now, if the fire department's already there, or maybe you're like the second ambulance coming in, then you can park all the ways up here. And the idea with this is that it's really easy to get out with the patient, right? So it's going to be harder to navigate all of this and running over hose lines and hydraulics and the jaws of life. If you park right here, you can easily just pull out. So that's how you determine where you're going to park. If there's somebody there already that's parked like this, then we can go and park in the front. If you're the first one getting there, then you need to park like that. All right, I hope that made sense. So let's say we get there and we notice as the flight crew that nobody's parked like that. We would have to direct, can somebody set up a block, right? Block off that situation. Because you can land and just get in the habit of, I got to run and check on the patient, but you have to think beyond just the patient in front of you. You have to have good situational awareness. Now, when you get on scene, and this is not just flight, this is ambulance, any medical personnel, you are likely going to be directed to the patient, right? And it's very common here for them to try to get you in the vehicle. Hey, can you come over here? Hey, we need a medic in here right now. And you, as the medical provider, this is what we wore. We wore t-shirts with like blue work pants, like mechanic pants, and our reflector jacket. And so if you don't have extrication gear, if you don't have rescue gear, look at all the metal in this. Look at all of this. And you are, whatever, I signed up for this job to help people, and you crawl in there, and then next thing you know, you're cutting yourself up, you're contaminating yourself and the patient. And so what I've done is, if I am working for a place that does not have helmets and goggles and gloves, I'll say, yeah, that sounds good. Let me borrow someone's jacket and helmet, because I'm not going to crawl into a vehicle and slice myself up and then not be able to take care of the patient. So if you're the owner of a program or the director of a program, make sure your EMS has extrication gear. Now, I do know there's some systems like this system. This is out in LA, I want to say, San Francisco. I don't know. They will say our EMS does not crawl into the vehicle. That's just like a rule. So fire has to extricate them, and then we will start to take care of them. And if that's your guidelines, then that's your guidelines. But if you are expected to start rendering care when you get on scene, you got to make sure that you're getting the proper stuff. The other thing that's important is, before you go crawling in a vehicle, you want to make sure that the vehicle is stabilized. So when these vehicles roll on their side or they roll over, and then all of a sudden they start cutting them, they want to make sure that they're cribbed. And so cribbed is where they can do whatever it takes. You see this long pole here. It's just preventing the vehicle from moving while you're trying to get the patient out. So before you enter that, proper PPE, helmet, goggles, gloves, at the minimum, a helmet and gloves, and maybe a turnout gear jacket. They usually got extras in the rescue truck. And then make sure you ask, is the vehicle stabilized, right? Make sure you ask, is there any fluid leaking from the vehicle? Was the vehicle on fire? Do you guys have a hose line ready if the vehicle were to start on fire? Have the airbags been deactivated? That's a huge one, right? There's all sorts of videos of emergency responders getting in there, and then the airbag blows out. So these are all questions you want to ask before you just run to the patient and, start an IV. You want to make sure it's safe, because if you're not not safe, you obviously can't take care of the patient. All right, so we get the patient out and we are walking back to the helicopter. We want to make sure that they don't have any baseball caps on, loose items of clothing. If they had a blanket over top of them, make sure it's strapped down to the cot. Make sure there's no loose papers, flushes, line. Everything needs to be secured. And so we have this life blanket, it's called, and we wrap the patient up like they're in a cocoon. And we make sure that none of the people that are going to help us load them into the helicopter have any hats on or anything that could blow off. So now we start walking up to the helicopter, and this is the caution zone. So we want to approach over here or over here. And that's because the rotor dips down on our aircraft in the front. Most aircraft, it's in the front. And so you want to approach from here, but you also want to check because there are some rotors, I guess, that are a little different. So we would approach from here. You could approach from here, but it's not recommended, right? So we come from here. We make sure before we enter the rotor disc, we look at the pilot. Thumbs up. Yep, thumbs up. And then we will load over on this side right here. And so we'll get them loaded in. I'll stand here and make sure that the EMS or flight team are able to walk back and get safely out of there. I'll make sure all the cabinets and stuff are closed, close the door, and then I'll walk around over here, and then we will lift off and take the patient to the hospital. Now, I think it's important that for a flight crew that we call back the ground crew and let them know how the flight went, right? Because they're only seeing a small piece of the puzzle. And so they will wonder, what happened to that patient? Did I make the right call calling a helicopter? Did the patient deteriorate? Did they go right to a cath lab? Did they go to the trauma room and they crack the chest? So we always try to call the ground crew and we let them know how the patient did. And all these systems have to come together to create this optimal condition where a patient who maybe did not have the best chance of survival now does. And we can use the technology, we can use good communication, we can use good situational awareness, and make sure that every link in the chain comes together to get that patient the best chance possible. All right, I'm going to leave you guys with a quote from my old paramedic instructor. He said, "Your ability to plug into the system, stay adaptable, and think beyond the patient in front of you is what keeps chaos from winning." His name is George Blankenship. So huge thanks to Ricardo for inviting me again to talk with you guys. We have this whole class recorded inside FoamFrat. If you want more information on that, just hit me up. My email is tyler@foamfrat.com, tyler@foamfrat.com. And I'd be happy to take any questions that you guys have. Let's see. Oh, it says to enable the language interpretation feature, please click on the globe icon at the bottom of your screen. I probably should have seen that earlier.
¿Alguna pregunta por parte de alguien? ¿Alguna pregunta?
Yeah, I'm sorry if I didn't see that until just now. Awesome. Well, thank you guys so much. Ricardo, you can text me and let me know if you need anything else. I appreciate it.
Tyler, te agradezco mucho en nombre de la universidad, en nombre de todos los paramédicos de Ecuador y todos los asistentes de estas jornadas. Una ponencia increíble. Otra perspectiva. Nos mencionabas que revisaste un poco sobre operaciones de vuelo, helicópteros de aeromédicos de aquí en Ecuador. Lamentablemente no hemos evolucionado tanto, estamos todavía en pañales iniciando. Esperamos en algún momento poder tener la logística y la infraestructura como en Estados Unidos y poder tripular a los pacientes que requieren transporte aeromédico desde el prehospital y no únicamente como transporte secundario. Agradezco nuevamente por tu ponencia y les invitamos a todos los participantes a seguir a Tyler y FoamFrat. Tienen mucho material educativo de gran calidad y nos puede ayudar a llevar nuestro nivel académico a otro punto. El conocimiento es internacional y este es el mejor ejemplo. Muchas gracias, Tyler. Esperamos poder contar contigo en otra ocasión. Gracias. A ver.
Bueno, con esto cerramos